Hi, my name is Edward Boas, and I'd like to tell you about a new method for CT metal artifact reduction that we've developed at Stanford Hospital. Here's an example of a patient with bilateral hip replacements, and you can see the streaks arising from the metal that degrade the image quality. The reason for these streaks is that filtered back projection, which is used to reconstruct CT images in clinical scanners, assumes that the projection data are equally accurate. In reality, X-ray beams that go through metal have much lower photon counts and much higher error than rays passing through soft tissue. This increased error is due to several different mechanisms, including Poisson noise, beam hardening, scatter, and motion of the metal. To reduce CT metal artifacts, we developed a technique called the Metal Deletion Technique, or MDT. The basic concept behind MDT is to delete the inaccurate metal data and then use forward projection to fill in the missing data. There are several other things that we had to do to get this to work. We iterate the procedure in order to improve image quality. We apply an edge-preserving blur filter before the forward projection to reduce noise. And before starting the reconstruction, we adaptively expand detector elements in regions with low photon counts in order to reduce Poisson noise. We first tested MDT on simulated scans of a phantom containing soft tissue and water with 2 metal implants and a small bone implant. We compared MDT to FPP and the linear interpolation technique. LI is a standard metal artifact reduction technique that involves deleting the metal data and replacing it with linearly interpolated values. We tested these reconstruction techniques on exact projection data and also projection data that has been corrupted by Poisson noise, beam hardening, motion of the metal implants, or all 3 factors. As you can see, MDT, which is shown in the last row, reduces metal artifacts due to all 3 different mechanisms for generating metal artifacts. Next, we tested MDT on clinical scans. These are embolization coils reconstructed with FPP, LI, and MDT. These are dental fillings reconstructed with FPP, LI, and MDT. These are more embolization coils reconstructed with FPP, LI, and MDT. These are cholecystectomy clips reconstructed with FPP, LI, and MDT. And finally, these are bilateral hip replacements reconstructed with FPP, LI, and MDT. As you can see, MDT reduces artifacts in a wide range of scans containing different types of metal implants. It also avoids introducing new streaks. For example, in LI, we see new streaks between metal and contrast excreted by the kidney. We reconstructed 178 slices with metal artifact from 11 different scans and asked 2 radiologists to independently rank the image quality. MDT was always given the top image quality rank. LI was usually in second place, and FBP and SART tied for last place. SART is another metal artifact reduction technique, which we included for comparison. You can see that the error bars are very small. The difference in image quality is not subtle at all. Now, improved image quality is good, but in order for this to really be useful, it has to affect the diagnosis and improve patient management. Here's the scan I showed at the beginning of the talk from a patient with a history of rectal cancer who has bilateral hip replacements. When we reduce the metal artifact, we see enlarged perirectal lymph nodes. Unfortunately, this was done as a retrospective study, and by the time we saw this image, the patient had already died. He was thought to be cancer-free at the time of death. An autopsy showed recurrent rectal cancer. Here's another example. This patient has a pacemaker, and the scan was originally read as concerning for perforation of the pacer wire through the right ventricle. When we reduced the artifacts, we see that it was simply the streak that went outside the ventricle. The pacer wire itself was safely within the ventricle. These are the first reported cases of a metal artifact reduction technique potentially changing the radiologic diagnosis. MDT isn't perfect, and the main limitation of this technique is decreased resolution near metal. This is due to the fact that we throw away projection data that involves metal. However, once we get more than a few millimeters away from the metal, the resolution returns to normal. In conclusion, MDT reduces metal artifacts due to multiple different mechanisms. It has better image quality than other techniques, and the improved image quality has the potential to change the diagnosis. Finally, MDT works on a wide variety of scans, from hip replacements to moving pacer wires, without any manual steps or adjustment of parameters. I would like to thank the people who helped with this project, and in particular, Dominic Fleischman. We've been using MDT clinically at Stanford Hospital as part of a research protocol. Today, we are launching a service to make MDT available to radiologists outside of Stanford for research use. This service works with DICOM files, which is not quite as good as using the raw data files from the scanner, but is much more convenient. Please check this service out, and I would love to hear your feedback. Thank you very much. If you're interested, the final 2 slides cover the technical details of MDT. We start with the projection data from the scanner, which is shown here for a single X-ray tube position. We then generate the FBP image, which is shown here. The metal pixels are highlighted in red, and projection data that involve metal are also shown in red. You can see all the artifacts around the metal, which are caused by the inaccurate metal data. To reduce the artifacts, the metal data can be deleted and replaced with values linearly interpolated from adjacent data. This is called the linear interpolation technique. As you can see, artifacts are significantly reduced, but there is still a streak between metal and this speck of bone over here. This streak is due to the fact that the bone should show up as a spike in the projection data, but it doesn't because the linear interpolation technique just fills in the missing data with a straight line. To further reduce artifacts, we apply an edge-preserving blur filter to reduce noise, then use forward projection to replace the missing metal data. With the forward projected data, you can now see that the speck of bone shows up as a small spike in the projection data. This is iterated 4 times, and the final result shows that the artifacts are pretty much eliminated. There are a few tricks that we employ to get the best results. One trick is to adaptively expand the detector elements in regions with low photon counts. This reduces Poisson error. In this example, we have 50 detector elements shown on the x-axis. The number of photons detected is shown by the dotted line, and in this example, we aren't detecting many photons near the center of the row of detector elements. We thus adaptively expand the detector elements, as shown by the red line, and this gives us an adjusted photon count, shown in the gray line, which is much closer to the exact expected photon count, shown in the black line.